the panel members so that the echo problem does not occur there. So tonight we have Dr. Gurunath Parale as speaker, and he has taken up a very important topic, AMI with comorbidities. We know how to deal with AMIs, but we often land up in problems because of the comorbidities, and so this becomes a very important topic. And on panel expert we have Professor Dr. Bali sir, who is a well-known figure to every one of us. Dr. Bhupen Desai from Mumbai. He has been roped in by Dr. Parale and myself. We are missing yet Mukul Bhatnagar. He must be cycling it at Rajendra Prasad Medical College. And we have Sourabh, who is youngest among the lot and a very bright student he has been. He is assistant professor at Safdarjung Medical College, New Delhi. And Dr. Ajit Kulkarni, who was just junior to me and had been at Hyderabad and now runs his own hospital at Raichur. So, sir, please, we can go.
Thank you, Dr. Smith. Thank you, Dr. Bali, sir, Dr. Desai and other panelists. When I started my practice in Solapur, somewhere around 28 years ago, I was the only cardiologist in an area of around 250 square kilometers. And that time, most of the referrals of infarction used to come to me from this area of around 2 to 3 districts. And that time, the decision was only whether to thrombolyze or not to thrombolyze. Few years passed, then some ICUs started coming up in the periphery, in taluka places. And the referrals now, the decision was whether to thrombolyze or to do PAMI, depending on the patient affordability, basically. Now, few more years have passed, and now some cath labs also have come. Many cath labs in the taluka places now here in Solapur district. And now I am get referrals only with the patients who have some comorbidities or they are VIP patients. So the spectrum of infarctions which is presented to me is changing. Now nearly more than 30-40% of the patients which I get have some sort of comorbidities. And comorbidities are, you will see, these are the usual comorbidities which we all come across. There is chronic kidney disease, stroke, liver disease, so on and so forth. We also know that as the number of comorbidities increase, the survival decreases. The problem about treating comorbidities is we are aware that there are no randomized trials on the subject. In fact, most of the trials which deal with the treatment of infarction exclude the patients with renal disease, kidney disease, liver disease, and so on and so forth. So we don't have definite guidelines. So what we have to rely is on anecdotal reports and some retrospective studies, and we have to individualize treatment. I know today's audience is very learned audience and highly academic audience. So whatever the thoughts which I am expressing today is rather sharing of thought and is a learning experience for me, because you can, whatever the suggestions which I am going to make in my subsequent slides, you can delete those suggestions, improve upon them, refine them, modify them, because I know you also have been dealing with such cases day in and day out. So this is not a final word, but these are certain thoughts. While I scanned the literature, that scanning may not be complete. It might be incomplete. I am aware of that. But these are the thoughts which I have got. Now, these are all cases are my real life cases which I have encountered and which made me wonder how to treat the subsequent patient if I encounter the same case. Now, this was a 67-year-old, my MD teacher. He had a long-standing diabetes. He came with inferior MI and shock. His creatinine was 2.3. Now, these are the two problems. He was my teacher and his creatinine was high. Any other patients, I would not have wondered much about the decision. But for him, I had to think whether I should go ahead and do PAMI. Now, we all know the problems of chronic kidney disease undergoing PCI. The acute problems we all know are the bleeding problems, or a stent thrombosis, or a contrast-induced nephropathy, and patient might go into a permanent maintenance dialysis. The long-term problems are the disease progression or a restenosis in the stent. This we all are aware. We know that as the GFR goes down in myocardial infarction, the mortality increases. These are well-known facts. We also know that the primary angioplasty benefit in infarction reduces as the GFR goes down. Coming back to our patient, my teacher, I did his angiography, which revealed near total proximal right coronary lesion. I did stenting with 40 ml of contrast. Hemodynamically, he immediately settled, his BP improved, and he was symptomatically better. But over the next few days, his creatinine gradually increased, and he required long-term maintenance dialysis. Now, although the relatives didn't express, I could guess from their expression that they blamed me and the procedure for his renal failure and dialysis. And it made me a bit of guilty, and I started to wonder whether my decision was right. And I decided to go through the literature and whether I could have done something differently or whether I can do better in my next similar patient. Now, the problem when we encounter a patient of infarction with chronic renal failure is twofold. What should be the primary treatment and what should be the ancillary treatment? Whether it should be a thrombolysis or whether it should be angioplasty. Thrombolysis is not contraindicated in chronic kidney disease. Now, about the ancillary treatment, whether we should use heparin or whether we should use low molecular heparin, whether we should use ticagrelor or whether you should use clopidogrel, and which sort of GP2BA antagonist should we use? And if a patient requires anticoagulation, like suppose he is in atrial fibrillation, suppose he has LV thrombus, and then what should be the oral anticoagulant that we should use? So we have, let's go through whatever literature we have. We know now this is a large registry over a 5-year period of the angioplasty done in myocardial infarction. It has been found the benefit of angioplasty decreases as the renal function deteriorates. This also is well known. Now, this is I know you are not able to see this slide. This is the largest registry that we have, GRACE registry, which compared head to head primary angioplasty versus fibrinolysis versus conservative treatment. So most of our data, or most of our, what you say, semblance of a guideline should come from this. The gist of that registry is that in moderate renal dysfunction, primary angioplasty is preferred over fibrinolysis, which is preferred over conservative treatment, because it improves not only in-hospital mortality, but it also improves 6-month mortality. So in moderate renal dysfunction, yes, you go ahead with PAMI, so nothing to think about it. However, if the renal function is severe, then use primary angioplasty only if the patient is hemodynamically unstable. Like if the patient is in heart failure, a patient is in shock, arrhythmias, intractable pain. But if patient is stable, in infarct, if the renal function is bad, then you should neither do angioplasty nor should you fibrinolyze, and you should conserve him. That was the message. Now, what is the ancillary treatment? It is said that ticagrelor is preferred over clopidogrel because it reduces stent thrombosis. This is according to Plateau trial. Then if you have to use GP2BA, if it is a large thrombus and you have to use it, then apixaban is the drug which you use. Don't use epifibatide or terifibran because they have renal excretion. Anticoagulation, it should be heparin, and low molecular heparins are contraindicated. Similarly, warfarin is preferred because most of the direct oral anticoagulants, they have a renal excretion.
So this is the ancillary treatment, and this is the some sort of guidelines which I'd like to give if you are faced with a STEMI and chronic kidney disease. Now we all are always afraid of contrast-induced nephropathy. There are nothing which you can be randomly applied guidelines, but let's see the fact file. What is contrast-induced nephropathy? Absolute increase of creatinine by 0.5 milligram or 25 increase over its baseline within 48 to 72 hours. Many times the creatinine does not increase the next day. It increases on third day or fourth day. So you should repeat creatinine on third or fourth day. Otherwise you can miss contrast-induced nephropathy. It is because of the renal vasoconstriction or acute tubular necrosis. We don't know for sure. What are the risk factors for contrast-induced nephropathy? If the baseline creatinine is more than 1.5, the patient is a diabetic, heart failure, and anemia. Remember, this is one factor which is correctable. Is in advanced, has advanced age, is in shock, or is on some nephrotoxic drugs like NSAIDs. So these are the risk factors, and you have to be sure when you are treating with or giving a contrast whether your patient has these additional risk factors, so you can take additional precautions. Intra-arterial contrast carries more risk than intravenous contrast. This fact has to be remembered. Then if you can space the procedures by minimum 3 days. Suppose you do a diagnostic angiogram and delay the angioplasty by 3 days. Ideally, there should be a 10-day gap, but minimum 3 days if you can. But of course, many times the patient is hemodynamically stable and you have to do an ad hoc procedure. Suggestion is restrict the contrast to 30 ml for a diagnostic procedure and 100 ml for an interventional procedure. That is some recommendation by some isolated studies which we have. These are the risk nephropathy, and this is a scoring system. The important thing is these you can roughly, for a theoretical purpose, you can explain it to the patient, to patient's relative, that this is a chance the patient might go into a renal shutdown or might need dialysis. So this is a rough scoring system, and that depends upon hypertension, whether patient needs IABP, is in heart failure, whether it has advanced stage, anemia, diabetes, how much is the contrast volume used, and what is the baseline creatinine. So you can, this is a rough score which can give you a rough guide what are your chances of patient going into a permanent renal shutdown. Now, what are the preventive measures you can undertake? The proven preventive measure is only volume expansion. You give it before, during, and after procedure. That's the only thing. If patient is in heart failure and you cannot give volume, then acetylcysteine 12 milligram a day before and after. That's the drug to be recommended. Diuretics, mannitol, soda carb have no additional benefit. Prophylactic or dialysis immediately after the procedure has no role. Now about the contrast agent used. In fact, I was surprised. I don't know, because some contrast agents are better than the other. And I found that the only isoosmolar agent which we have today is iodoxanol. And that is the best if you can use, and if it is available. And I think it's, after going this literature, I have made it available on our shelf, and this is a contrast agent which I use. If not, you have other. There's a next slide which will tell you that the milliosmolarity is the best thing which predicts the contrast-induced nephropathy, at least in human beings. Viscosity is the other thing which plays a role, but it has not been proven in human beings. It has been shown in experimental animals. Iodoxanol is the only which has a least osmolarity and is isoosmolar with the plasma. Plasma osmolarity is 275 to 295. So this is the one which is isoosmolar, and the brand name which we have is Visipac 320. This is the brand name which you have, and the only downside is you will see the iodine content is slightly less, 320 concentration. So if your lab quality is not very good, you might have some image issues. But if your lab quality is recent, then flat panel labs, then perhaps that doesn't become an issue. So these are the things which, if you don't have Visipac, you can use the other contrast agents which have a low osmolarity. Osmolarity in the range of around 600 to 700.
and high osmolality agents should be avoided. That's the thing which I came out with from the literature. And ultimately, discussing all this, the message which I got, a fear of contrast-induced nephropathy should not deter the treating cardiologist from doing PCI in ACS, heart failure, and shock. So in some way, I thought my guilt, I could do away with my guilt, and that was some solace when I got those findings. The thing which you remember, the risk of acute kidney injury following CABG is 2 to 4 times than that of multivessel PCI. Remember, whether it is the off pump or on pump, whatever little head-to-head comparison is there between PCI and CABG, multivessel PCI is preferred if there is a basal renal dysfunction. And so it was to happen that another of my teachers, few days got admitted, another of my MD teachers got admitted with ACS and left ventricular failure. His baseline creatinine was high. With now I took all few precautions, talked to the relatives, talked them that there is a chance of he might go into a permanent renal shutdown and might need a maintenance dialysis. But he underwent PCI of LAD without any complications or renal shutdown, and for it is 4 years down the line he is still dialysis free. So it is as unpredictable as that. That's the message I think we would like to have. Now, word about troponins in chronic kidney disease. We know the troponins are increased in kidney disease. Then when should we consider them as significant? You repeat them after 6 hours. If there is 20% change in either direction, it increases or it decreases, then you should consider that episode as a fresh episode. Troponin I is slightly more specific in chronic kidney disease than troponin T. And they may retain their prognostic role as in any other patients. So that was the first comorbidity that we discussed. Should we go to next comorbidity? Or Dr. Bali sir, you have to add anything to this?
And then go on to the issue.
Discuss it at the end.
Whatever way you decide, because I think there are going to be a number of topics, and in the end we may lose out on some important discussion. So we can have a couple of minutes discussion now, and then go.
Sure.
Dr. Parale, you mentioned about the use of various, and it is well known that most of the labs are using VisiPake as the contrast medium, and hydration is the only thing which has been shown to be of value. But you did mention that acetylcysteine has to be shown to be of value, which I think probably the large trials have proven, although we continue to use acetylcysteine, that it is not very effective. The other thing is that contrast should be limited, we know that. And people have tried other maneuvers also to take care of that. One is preconditioning of the kidneys, which has been tried, and recently, about 3 months back, a trial came, preconditioning by blood pressure cuff. And about 3 months back, a trial came, head-to-head trial, which showed that this preconditioning does not help. Then other people have tried putting a catheter into the coronary sinus and taking away from the coronary sinus the contrast and limiting the exposure to systemic circulation. But most of the people believe it is a one-time at the end, maybe oxygen-free radicals have a role to play in contrast-induced nephropathy. But all said and done, what we need to do is we must hydrate the patient very well and hydrate very well, despite the fact that they may have left ventricular dysfunction and all. The other factor is that I probably have a little different opinion about not doing any treatment in these people where you cannot do a primary angioplasty, conservative management. You very rightly said that saving lives is more important, and there will be a lot of treatment of acute MI where we would be interested in saving lives, and we would have the data to show that it saves lives. So whereas what I do is you have a detailed discussion with the family, and you spend sufficient time to explain to them that despite the fact that GFR is so and so, he may require no dialysis, he may require one dialysis, he may require multiple dialysis, or he may become dialysis dependent. But once you have explained to them and involved a nephrologist who would explain to the family that saving life and saving myocardium takes precedence. And we must remember that large majority of patients of chronic renal failure die of cardiac disease, not of renal failure. So cardiac evaluation, cardiac treatment, and intervention is a very important component of these chronic renal failure. You touched only myocardial infarction, but there are situations where you may have a creatinine of 4, 4.5, and patient may have disabling angina or unstable angina. So we might have to intervene. In fact, we have a large series of patients of renal failure because I worked in a center where transplantation program was very active, and then about 20 dialysis going on in one shift over 3 shifts. So you see a number of these patients, but you need a very clear discussion with all of them. And other than hydration, none of the other factors have been shown to be of great value other than the isomolar contrast. Your comments, Bhupen?
I fully agree with what you said, Dr. Bali. The most important part, Dr. Parale, is to speak to the relative, take a high risk consent. Straight away tell him that this man will require dialysis, maybe permanently. Secondly, you tell him there is a more chance of bleeding and more chance of stent restenosis and stent thrombosis. And as he rightly said, hydration is the only thing, nothing else works for that. Now we have some data with rosuvastatin. So you preload them with rosuvastatin. Rosuvastatin prevents contrast-induced nephropathy. And about your low molecular weight heparin, unless it is an end-stage renal disease, you can use low molecular weight heparin. You can use enoxaparin a slightly lower dose, or maybe you can use fondaparinux if you want to use that. Because heparin is very unpredictable. You cannot keep on checking that PTT and all those things. And secondly, if your patients are not...
Dr. Desai, I just want to interrupt you. This was peri-procedural heparin.
Yeah, peri-procedural, yes.
Here you can monitor with ACT, so that would be better.
No, I believe we are all using peri-procedural heparin. Very few of us are using low molecular weight heparin during the procedure. And finally, you can thrombolize them. To the best of my knowledge, when a acute MI comes, we don't have time to check for creatinine. Many times we have done a PAMI and then the creatinine report came after 3 hours of creatinine of 5 or something. So when we take patient for PAMI, we don't have time to even check for creatinine. Thrombolysis is relatively safe also, in my opinion, if you have a renal failure also. It doesn't make any difference. But hydration...
One more point I'd like to make. That now we have some data coming up that under intravascular ultrasound, IVUS, you can do a angioplasty. You would need a very limited contrast to diagnose. And at least in stable patients, chronic stable, what we call as a chronic stable disease, or in acute coronary syndrome, where we have angiographic findings available, entire procedure can be completed under intravascular ultrasound. I personally do not have experience of doing that, but there are reports in world literature available now where you can complete the entire procedure under intravascular ultrasound also. So that one should be with a larger amount of availability of imaging techniques. That's another evolving thing which we should be aware of.
Basically in stable patients.
Yeah. Where you have angiographic findings available, yes.
So as you rightly say, contrast volume is very important. So you take very few shoots. We have a habit of taking several views before and after the procedures to look at that thing. So you take very minimal views. And VCPEC is a horrible. I have used VCPEC, but the image quality is very bad. And rightly say, unless you have a top class lab, it is very difficult.
Sir, any experience with CO2 angiography? Because recently one of the industry person was pushing CO2 angiography to buy the injector at our center.
The initial data came of CO angiography in renal angioplasty primarily. Yeah. And in renal angiography, you can do that with the CO angiography. I do not know what type of quality of imaging is available with CO2 in coronary. I don't know, but renal angiography, yes. There was a time when renal angioplasty was done in a patient borderline renal function and only one functioning kidney, or critically narrow one functioning kidney, and things like that. It was tried, but I don't know what coronary artery disease on the carbon dioxide.
And second is, should CT angio be preferred if we have an emergency CT angio that can be done?
CT angio, you have to use nearly 80 ml of contrast.
Yes.
Contrast is nearly 80, minimum 80 ml contrast. Of course,
it is not advisable.
One of the slides had IV is better than intra.
Yeah, true.
In
The
fact,
amount of dye you require is much high.
would not do a CT angiography.
Should not do it.
We will not cross that test. So we will not reach to a stage where we have a CT angiography. I think an intra-arterial muscle amount of dye is what the way to go ahead. Yes, we can go ahead.
Okay. Coming to the next comorbidity, that is stroke. Recently, I had a 35-year-old patient with acute left hemiparesis of 2 hours duration. His ECG revealed, because he was in shock, his ECG was recorded, and ECG revealed acute entry infarct. He was in cardiogenic shock. The problem was whether to treat heart first or brain first. Now we have to deal with these situations in different scenarios. We are basically cardiologists, so we are interested in treatment of infarctions. So if you have acute infarction and if you have stroke, whether that stroke is less than 4.5 hours, that is a thrombolytic window for stroke thrombolysis, whether that stroke is more than 4.5 hours but less than a month, if it is more than a month, and last, whether stroke is because of intracranial hemorrhage. Now we have to take a decision, heart first or brain first. Now let's get some facts right. We know that IV thrombolysis is beneficial for both. The reperfusion window for stroke is smaller than heart, that is 4.5 hours. But the thrombolytic dose used for STEMI is much higher than the ischemic stroke. And hence, if you thrombolize for heart, you can produce hemorrhagic transformation in brain. That's the downside of it. Then, if you thrombolize for brain, antiplatelet agents are contraindicated for next 12 to 24 hours after stroke thrombolysis, and which are absolutely indicated for infarction. Then, if you do PAMI, you have to give heparin, you have to give DAPT, you may have to give GP2B. So all this can increase or can produce hemorrhagic transformation, which is the most important thing that we are worried about. Now, what are the predictors of hemorrhagic transformation? There are only 3 important predictors. One is advanced age, second is renal impairment, and third is infarct volume, a large infarct. Interestingly, neither the use of anticoagulation of heparin or warfarin are significant predictors of de novo hemorrhage, although they can increase the existing hemorrhage. But occurrence of hemorrhagic transformation is not dependent on the use of heparin and warfarin if they are in therapeutic dose. The other important fact that we have to know is 75% of hemorrhagic transformation occurs in 4 days and rest in 3 weeks. So these facts we have to bear in our mind when you take a decision. So coming back to our patient, a stroke less than 4.5 hours, ideally mechanical thrombectomy for stroke and primary PCI for MI at the same setting. If this is feasible, it's not feasible in my setting. I don't know whether it is feasible in your setting. If the patient is unstable, hypotension, arrhythmias, as our patient, he was in shock, heart first, go ahead with angioplasty. If the patient is hemodynamically stable and a large brain vessel occluded, then you do thrombolysis first for stroke and do PCI 24 hours later when your DAPT can be given. If the stroke is more than 4.5 years old and less than a month, you have to individualize strategy. If it is a small lacunar infarct volume is less, go ahead with primary PCI. If there are chances of hemorrhagic transformation, like if it is a large infarct, renal dysfunction, then just do a thrombus aspiration, don't put a stent. You may do a POBA only, so you can avoid aggressive anticoagulation and antiplatelet treatment. If it is more than a month, stroke is more than I think the choice is very clear cut. PCI, thrombolysis is contraindicated up to 6 months. So PCI, you shouldn't have have any doubts about it. You go ahead with primary PCI. About the ancillary treatment after PAMI. A single dose of periprocedural heparin is safe. Even if you have a concomitant strain, it does not induce hemorrhagic transformation. Aspirin can be safely administered. Clopidogrel is preferred over ticagrelor. And one trial suggests even if needed, abciximab can be given. As I have mentioned earlier, anticoagulation of heparin and warfarin does not increase the incidence of hemorrhagic transformation. With my patient, it so happened that his first MRI was done. MRI showed a major branch of middle cerebral artery was occluded. And we were thinking whether to thrombolize for brain. Patient came out of MRI and his power improved. We took him back to MRI. That vessel was opening up. The neurologist said, now thrombolysis, the risk is more than the benefit, because the vessel is opening up and the benefit is less than the risk involved of hemorrhagic transformation. So he will not thrombolize for that patient. For cardiac wise, of course, he had indication. He was in shock. He had acute entry infarct. So I went ahead, did his primary angioplasty. Patient immediately settled. And fortunately for him, in next 6 hours, his power became absolutely normal. There was a spontaneous recanalization of a cerebral artery, and he literally walked home. Now, if there is STEMI with intracranial hemorrhage, maximum hematoma expansion occurs in first 24 hours. So if hemodynamic condition demands, you go ahead with primary angioplasty, as intraprocedural single dose of heparin is not risky. However, you should avoid aggressive antiplatelet regimen. Again, restrict to thrombus aspiration and plain balloon angioplasty. So this is for acute. Of course, these are rough guidelines. You will have to individualize and decide when you are confronted with a patient. Yes, Dr. Bali, sir. And no, not able to hear you. Not able to hear. Audio is off. Audio is off.
So now it is on.
Yeah, okay, fine.
Somebody else can make a comment and then I will come on. Okay.
Two things, Dr. Parale. Sometimes the acute stroke can itself cause a lot of ECG changes. So don't go only by ECG. If you have a feature like acute myocardial infarction on ECG, at least do some echo screening immediately. Make sure there are significant regional wall motion abnormality, and then think about it. And then you take a call what you want to do.
Yes, obviously,
not even MRI.
What we are dealing is an established case of infarction.
Okay.
So yeah. So
secondly, I don't think so. You should waste much time if you want to do a STEMI, PAMI. Don't waste time on the MRIs. Just do a CT scan and find out a negative thing. If there is no hemorrhage, straight away take him to the cath lab. Dr. Bali.
Can you hear me now?
Yes, sir.
I think once you have a patient of a stroke and with MI, first of all, you want to find out what is the relation between the two. It could be an embolic stroke from a fresh MI and a cardioembolic stroke. The other thing is that in my center, I am a very reluctant thrombolizer. In fact, for the last 15 years, there is only one patient which I thrombolized in the last 1 month of COVID time. Otherwise, I take patients for primary angioplasty. And fortunately, in my center, I have a very good neurointerventionist from PGI who is capable of, who does a stroke intervention very easily and very finely. So I think both of these procedures can be taken care of. Coming to your patient, we had an MRI, which probably takes a very long period, 45 minutes to do an MRI. I would have not waited for 45 minutes an MRI in a patient who had an acute interval myocardial infarction and a cardiogenic shock. I would have probably just taken him for a CT angiography if that had to be done. And if the artery is opening up by the time your procedure is finishing, imaging procedure is finishing, then we are not dealing with a stroke. We are either dealing with a TIA or we dealing with a RIND, reversible ischemia. We're not dealing with a stroke. So question of treating that would not probably arise. But what I would like to say is that intervention is a safer modality in these patients. And in my view, anterior MI, cardiogenic shock should take precedence over treatment of stroke in these patients. But once you have opened up the artery through the same route, stroke can also be tackled subsequently. So first open up the primary culprit lesion in the coronaries and then open up the stroke. The other thing is I have seen patients where you may have anterior MI and you may have a carotid block producing a stroke, a fresh carotid artery-to-artery emboli producing a stroke. So again, we can do intervention. So my primary suggestion would be intervene and then take further evidence. Thrombolysis, I don't have too much of experience, so I would not be able to comment on that.
I fully agree with Dr. Bali. If you have a facility of neurointerventionist with you, I think you do both the procedures simultaneously. And whatever antiplatelet or thrombolytic or heparin you give, it will act in both the circuit. It will help you in both the area.
How to manage, sir, if patient is having peri-PCI stroke? While during PCI patient had stroke, then how will we manage it, sir?
You know, we used to have a lot of issues with this particular type of presentation in the era when we were doing mitral balloon valvotomies. Okay, you do a procedure and the thrombus, which you have probably missed on a TE or something, or there was a spontaneous contrast which you ignored or something, and an emboli would take place. Now, a large majority of interventionists today are trained to intervene for a stroke as well. Now, you have in the lab a solitaire available, and you can, most of us are very well trained in, maybe I did my first carotid angioplasty standing way back in '97. So we have intracranial angioplasty stenting done. Solitaire is a very easy device to use. The only thing which you actually need is a imaging to identify where the artery is blocked, so that you can take care of on the table. And actually, when you're doing coronary carotid angioplasty stenting on a DSA, you before and after the procedure, you do look at every small vessel, and if you find on table a vessel is occluded, you can take care of it. It's a fresh clot, and it can be taken care of. And solitaire is a very good device to be effective in this. In fact, my suggestion would be that all interventional cardiologists should have basic experience of doing neurointervention as well. I started doing some strokes, but then I thought at my age, I don't have to go in the middle of the night and chase them. Let a neurointerventionist do it. But you can land up on the table, as very rightly pointed out by Dr. Sourabh, and you should be prepared to chase that from us.
Well, what is the role of intracranial thrombolysis in that scenario? If you have an embolic stroke on the table, selective intracranial thrombolysis.
You know, I don't have too much experience, but what I can just from theoretical basis I can say is it will depend on what type of a clot you're dealing. So if it's a fresh clot, you probably would succeed. But sometimes you have an organized clot which goes from an intracardiac chamber. And as I was mentioning about the LA clot, the clot may be organized and it goes. Probably it may not open up with the intra-arterial thrombolysis. But I have no experience of intra-arterial thrombolysis in a cardiac.
What is the dose? What is the dose which you give for intracranial thrombolysis? Anyone? What is the dose for local thrombolysis?
No idea. But I'll share you one of my experience.
Really, they use
in space of about a year back, in space of 8 days, we had a 3-stroke peri-procedural. Fortunately, we did not do angioplasty of all these 3 patients. They were multi-vessel disease, plan for surgery, severe LV dysfunction. And the moment we took him out of the cath lab, we realized that patient has done a deep stroke. And we had to call our neurologist. Fortunately, they were all three were done with radial artery, so we thrombolized them with ectylizer. All of the three improved, and then finally we realized that heparin was defective. That it was all procedure-related thrombus formation, and then we checked for the heparin, removed that batch, and then we found several other hospitals had a similar problem during same time in Bombay. So lucky we did not do intervention, but we were all three had a after angiography. So luckily we were able to thrombolize them. There was not too much of heparin or anything were given. But heparin
suggestion I'd like to give
is always very difficult.
One suggestion I'd like to give, most of the interventional cardiologists tend to panic if you see a stroke on the table.
Yes,
my suggestion would be you have time on your side. Stroke takes much longer time to evolve than our MI does. So you have time, you can actually do a good and carotid angio and find out which artery is blocked, a good DSA. In some lab, you will have a three-dimensional reconstruction. You can have a very good DSA and rotational angiography to see which particular branch is occluded and chase it. So don't panic. There are options available and you have time on your side.
How much does thrombus aspiration work in carotid circuit? Does our routine thrombus work there?
Dr. Parale, our thrombus or whatever you have, aspiration catheter, is a 6 French device.
Yes.
And we are talking of a branch of a middle cerebral artery or an anterior cerebral artery getting occluded. So that is quite small. But now if you look at the armamentarium, what neurointerventionists have, they have microcatheters which are 0.10 wire compatible. And you can, through that microcatheter, you can address any of these small branches. And this solitaire is basically removes the clot. It's a device which removes the clot. So you open it up, the clot will get entrapped and you take it out. So it is like passing a wire and deploying that solitaire device and taking it out. So the coronary aspiration catheter would not work. So you would need a specific neurointerventional method, but the coronary microcatheter would work. But then you will have to see the length of the microcatheter and things like that. So it's a good idea to have a neurointerventional, if not a neurointerventional, at least the hardware which they use available in the cath lab.
Okay.
So I could just Google what is the dose required. It is altiplase that is to be used. That is only recommended.
Yeah, altiplase they use.
And 0.9 milligram per kg. And to a maximum dose of 90 milligrams. Japanese recommendation is 0.6 because they had a different study where lower dose, had the same effect but caused less problems.
That is local thrombolysis.
For local thrombolysis.
Intra-arterial.
Directed.
Okay.
Can we go to the next?
Okay, coming to the next. This was a 65-year-old patient, known chronic liver disease. He had acute inferior-posterior MI in a peripheral hospital, was in cardiogenic shock, left ventricular failure. He was intubated, put on a ventilator, and was referred. He had a history of upper GI bleed a month ago. His platelet count was 68,000. He had undergone angiography 1 year ago, which had revealed 3 vessel disease. And he was given option of both angioplasty as well as bypass. But both cardiologists and surgeons, they were very reluctant and they explained him the risk. And naturally, he also was reluctant and didn't undergo any of the procedure. The issue is a patient of chronic liver disease, whether CABG is better or angioplasty is better. You give DAPT after angioplasty, there are chances of increased GI bleed. Whether you should, because of DAPT, whether you should prefer a bare metal stent or a drug-eluting stent. And now you also have low platelet count. So with this issue, the decision becomes quite complex when you deal with a patient of acute coronary syndrome and chronic liver disease. Now, this patient angiogram revealed a 3-vessel disease as expected, but the culprit lesion was a total ostial circumflex occlusion. I did only a POBA. I didn't want to complicate the procedure. Naturally, with that history in mind, fortunately for me, he improved and he was not from my place, and I was happy to send him home as early as possible. Now, about the revascularization chronic liver disease. This was a head-to-head comparison. It said that CABG versus angioplasty, the hazard ratio is 4. So CABG is definitely harmful than angioplasty. It is this is a conventional CABG. This is all CABG. The conventional means on pump CABG. So CABG, whether it is on pump or on off pump, it is bad. The on pump CABG is furthermore bad. Off pump is slightly less bad, but still bad compared to angioplasty. And naturally, the conventional CABG should be avoided if you can do off pump. So that is about, so in chronic liver disease, the message is the angioplasty is preferable to CABG, even if it is a multivessel disease. So PCI is preferred, surgery is avoided. Then drug-eluting stent is still preferred, despite the risk of DAPT, because this is a patient who is going to live a few years and you don't want a restenosis. The proton pump inhibitors should be routinely prescribed in these patients. DAPT can be safely administered as long as the platelet count is above 30,000. And aspirin can alone be given if the platelet count is about 20,000. That's it. Open for discussion.
I think this is a very difficult and a very controversial area. And we have to basically see, if we go, I will take you back in history, about 40 years ago, or maybe 35 years ago, when I was doing starting my post-graduation, the textbook would teach that patients of cirrhosis do not get atherosclerotic coronary artery disease. But that was an era when probably people would not survive to have atherosclerotic coronary artery disease. But now what we need to do is, when you're taking chronic liver disease, is a spectrum of disease. You may have a chronic liver disease, child A, child B, child POF A, B, and C, which is not a decompensated liver disease. In a patient who is not decompensated, you can go ahead and do a procedure. The problem with bypass surgery is more of a decompensated liver disease, and once you put them on ventilator, they would go into hepatic encephalopathy would worsen, and they would have problems, complications because of that. Angioplasty, whenever possible, could be done, and we have done about in 4 patients with chronic liver disease, angioplasty with drug-eluting stents and DAP, but they were all not decompensated patients. So I think angioplasty would be preferable, and absolutely you are right that if the counts are more than 30,000, you can use a DAPT. Clopidogrel, not the newer ticagrelor or prasugrel, but aspirin and clopidogrel 75 milligram can be used. And only you may have to actually change the dose from day to day. On the first day you give loading, and second day you find the counts have come down, and you may have to decrease the dose of clopidogrel from 1 DD to 1 OD, and then see what is the least amount of dual antiplatelet you can continue in that particular patient. Having said that, there is one option which you can consider for a bypass surgery, what we call as the awake bypass surgery. So where you have a beating heart surgery being done, where you are not using conventional ventilation, and probably that would be safer. But this is a very tricky situation, and you can have a decompensated liver disease. You can have a real problem at your. I do not know how do these patients with platelets counts 30 to 40,000 have acute coronary syndrome with the thrombus forming there. So there is a paradoxical situation here. Where thrombus formation, where the platelets are low, and probably platelet function may be defective or so. I don't know anybody has done a platelet study in these group of patients or not. But my suggestion would be angioplasty is the primary choice of treatment if the treatment has to be given.
Sourabh, I would agree with Dr. Bali. angioplasty will be a better choice. And now a lot of new data have come. If you use the latest generation, third generation newer stents, they are forgiving stents. There are many patients who do not take in my practice, but nothing happens to them. So use the best quality stent, newer generation, third generation stents, dual antiplatelet. If there's a more chance of bleeding, maybe after 1 month or 3 months, you switch off aspirin. Several studies have shown that aspirin is a culprit for the bleeding. Continue with clopidogrel. And there is, if you have a compensated liver disease, there is no harm in giving the full dose of statin also. There was a study called Greece study in which they have given in cirrhotic patients also rosuvastatin, and they found it to be quite effective.
Sir, how much heparin we have to give during PCI? We should keep the ACT low or normal ACT in patient having thrombocytopenia?
Like any other patient.
Dr. Bhupen, you mentioned about use of only clopidogrel. To the best of my knowledge, the only study which has used a single platelet in post-ACS or post-stenting patient is ticagrelor without an aspirin.
Twilight study, yes. So if ticagrelor can be useful,
I'm not aware of any study on clopidogrel alone.
No, I agree with you, sir. But the lot of studies have come with Novex and I think every study has blamed aspirin for the bleeding. So better to avoid aspirin if your patient bleeds. First 3 months, you give dual antiplatelet agent. But after that, if you have to make a judgment, one of the two you have to stop. So maybe in my practice, I will stop aspirin.
You are very right. There are stents like Synergy stent where there is a strong data to show, which we very commonly use in patients who are likely to undergo a transplant or some other surgery, where you need a dual antiplatelet drugs only for a period of 3 months. Well, that is fair enough.
Yes.
But only one antiplatelet from the beginning would be a little problem.
No, sir. After 3 months.
Yeah. Okay.
Not the beginning. There are some studies they have given an antiplatelet only for 1 month, dual antiplatelet for 1 month, and then switch over to only one.
But those studies are on non-clopidogrel drugs, because clopidogrel with its resistance is a problem.
Correct.
Yeah.
Correct.
That is. Anybody has experience of awake CABG? Any comments on that?
No.
No idea, sir.
One Dr. Zavli from Bangalore. In fact, he has an awake CABG.
We have 2-3 people. I think down south there are people who are doing awake CABG. I think in Fortis, Bangalore also it has been done.
Exactly. That is Dr. Zavli. That is.
That's not an issue. Technically, is not a problem. The problem is it safer than a beating heart surgery in cirrhotic patients? That is what I wanted to know.
I think the indication then in them was bad lungs. That was the indication, rather than liver.
If you don't mind, Dr. Parale, awake CABG means they will do it under what? Local anesthesia?
High spinal.
Okay.
We can go further.
Now, this is a patient, perhaps the last comorbidity which I'd like to discuss. Of course, there are a few more, but I think we will stop here after this. This is relatively a rare problem. This was a 56-year-old gentleman. He came with increasing angina for a week. He was hypertensive on beta blockers. There was no other risk factors. He had no significant past medical history or surgery, no history of surgery. His blood count and biochemistry was normal. His angiogram was done through right femoral root. Everything here matters. That's why I'm mentioning this. He had a very tight proximal circumflex lesion. And was advised PCI. He was ready. So ad hoc PCI was done. Was loaded with 300 milligram of clopidogrel, not 600. 325 milligram of aspirin. 7,500 units of heparin was given peri-procedure and ACT was around 400. PCI was done successfully, uneventfully, and this was the hardware used. Femoral sheath removed after 2 hours, manual compression given, and the problem started. Bleeding did not stop for next 4 hours. 4 hours, the Nurses, the technicians, they took rotations in compression, but the bleeding would not stop. I was thinking and in fact called the vascular surgeon. And that's the time something struck me and I gave him fresh frozen plasma and the bleeding stopped immediately. His all parameters were repeated and they were normal. Platelet count, bleeding time, clotting time, PT, APTT, everything was normal. But obviously he had bleeding issues or clotting problems. That was very clear cut. So investigated him further and he was found to have hemophilia type A. Now this is a relatively common type of hemophilia type A. Hemophilia type B is relatively rare. Now prevalence is, it is a disease of males, not extremely rare. It is 1 in 5,000 to 10,000, so not very rare. We might be missing. It is usually hereditary X-linked, but can be by mutation in 1/3. Previously, it was believed that CAD incidence is less in hemophilia, but it is known that it is as common in general population. It is a myth. The most common type of hemophilia, type A hemophilia, is a severe variety where the factor VIII concentration is less than 1%. The prevalence is 50%. The next common is a mild variety. The prevalence is 30 to 40%. And here the factor concentration is 6 to 30%. And moderate type is the least common of this. Our patients, my patients, factor VIII levels were 20%. So he fitted in the mild category. The important thing is the mild hemophilia patients can be totally asymptomatic throughout their life unless they undergo some invasive procedure or they have some injury where the bleeding doesn't stop, as in my patient. Even the routine clotting tests can be normal or only mildly abnormal, and you can totally miss this unless you carefully look for this. This patient I started on DAPT. He had easy bruising. So I reduced the dose of aspirin from 150 to 75 milligram. After a month, he had an episode of GI bleeding. I stopped clopidogrel and factor VIII was transfused. His bruising continued. I reduced his aspirin to 50 milligram. And now last 5 years, he is on only 50 milligram of aspirin and he is stable. So suppose if we encounter a patient of a known hemophiliac, if we encounter and if we have to do a procedure, what should we do? What will I do? I will avoid PCI if I can. Yes, that is the first thing, having faced that patient. Use a radial route than femoral for obvious reason. If you are using a femoral route for any reason, then use a percutaneous closure device and don't rely on manual compression. Build up factor VIII levels to between 30 and 80% during the procedure until 48 hours post-procedure when there are increased chances of bleeding. The dose of factor VIII is 15 to 40 units per kg every 12 hours till the time you are giving DAPT. You may use bivalirudin than unfractionated heparin. That looks an attractive option on paper, but whatever the literature I scanned, there were 56 cases. All of them used heparin. Then unfractionated heparin is again preferred over low molecular weight heparin. Clopidogrel is preferred over prasugrel for anticoagulant for obvious reason. You should avoid DP2BA, 3A, again for obvious reason. But if you have to use epiphybatide, which has a shorter half-life and there is low risk of thrombocytopenia. Again, avoid stenting if you can, again because of DAPT risk. If you have to use a stent, now you have newer days who require maybe a month. I think Onyx has got a CE approval. Maybe for a month you can give DAPT and then only a single antiplatelet, as I did in this patient. That's all.
You are mute, Dr. Bali. You are mute.
Yeah, I said at the outset, I would like to congratulate Dr. Parale for investigating for hemophilia this particular patient, and most of the time he would not be investigated. My comments are first on the technical aspects of the. You see a bleeding which would not stop from the femoral root, and one of the problem is that it may be increasing, and manual compression is not doing anything. So what we need to remember is once the hematoma forms there, with manual compression, you are not achieving anything. You are not actually compressing the artery. That is one thing. Number two is that you may be compressing the artery and the retroperitoneal bleeding may be increasing, which may be making things worse. And then we know now that once you have an arterial bleeding, we have not only hemorrhagic complications, which are increased in these patients, even the thrombotic complications are higher in these patients. So chances of stent thrombosis going up is also there. So we need to address femoral bleeding as rapidly as we can do. And the worst thing one can do is call a surgeon at this time, because we are already on antiplatelets. We have used heparin, and there is a hematoma which is around the femoral artery, and the surgeon would come and open up, and this hematoma will be displaced, and the bleeding there would be much more bleeding, which the surgeon would not be able to take care of. So I think you should not be calling a surgeon. What you should be doing is, if you have removed the sheath, obviously this is a post-mover of sheath, go from the contralateral side and do a balloon tamponade of the first femoral artery first to get a hang of the thing, what is happening up. Or if you are, after half an hour of balloon tamponade, you have occluded the artery with a femoral balloon, with a 6 millimeter balloon or 8 millimeter balloon, depending on the vessel size, you still have hematoma going up. We have a peripheral stent, covered stent grafts available, which you can deploy easily from the contralateral side and take care of it. That is, we should identify a femoral bleeding earlier, act fast, and act yourself, not depend on the surgeon. That is one part of rest of the things you have beautifully covered up. That radial is a much preferred treatment. Clopidogrel and aspirin combination to be preferred over neuroantiplatelets, and rest of the things are beautifully covered up, in particular this section.
Sir, I have one question, Dr. Bali.
Sir,
Trying to stop the right femoral bleed, what will happen if the left femoral starts bleeding? You've taken a contralateral excess. That will also bleed if it is hemophilia.
There is a we talking about problem, but that is not a very tough issue. You have a sheath on the left side. You can put do a tamponade there as well, and have sufficient time to rest of the thing is to diagnose what is happening. Give fresh urine plasma, give fresh blood, or whatever you want to give. Then you have time to come, but don't remove the sheath there. Keep the sheath there.
After some time, you'll have to remove the sheath.
No, I think that is why I said at the outset, I would like to congratulate Dr. Parale for
even I would congratulate
thinking of this possibility and going ahead and think of hemophilia. That was an extremely competent step to take.
Correct.
Because this would happen once in a lifetime to any one of us. But a femoral bleeding could occur because of a non-hemorrhagic diathesis also. So that is much more common. That occurs day in and day out. So you should be prepared to tackle it. Never call a surgeon. You will have unnecessary more problem on your side. But this particular thing was beautifully tackled.
Okay. So there are two questions. One is by Dr. Jayapattam. What is the risk of stent thrombosis in FFP transfusion post-PCI? And the second question is by Dr. Shadab Ahmed. Similarly, should protamine be used first or FFP should be transfused?
See, protamine, it was 4 hours. I think the heparin half-life is already over. So protamine obviously doesn't have any role. And having a FFP stent thrombosis is anybody's guess. I don't think
you can answer that question. FFP will provide you with the coagulation factor. It has nothing to do with the platelet. So platelet will not be affected. So long as your DAPT is on board, nothing will happen to the stent.
And Dr. Parale,
I would agree with Dr. Bhupen there. The problem is once you have bleeding occurring for a period of time, then you have a secondary consumptive coagulopathy coming along, and
Correct.
then you have a platelet issues as well coming up. So this is the faster you act, the lesser problem you have. But I agree with you that FFP probably would not have any effect on stent thrombosis.
It will not affect the stent thrombosis.
Dr. Parale, you can go ahead with the 2 more comorbidities because we had discussion in between. So we have not kept anything for the end.
Okay, maybe one comorbidity I'll cover. Okay, I think this is more for not for an interventionalist like Dr. Bali sir. Perhaps this topic is more for the physicians. COPD. Now, if you see the prevalence of diseases, while all lifestyle diseases, the prevalence is going down, the only disease whose prevalence is increasing is COPD over last few decades. The problem of infarction COPD is, it is the heart disease which is a cause for mortality in COPD. The problem of heart disease or infarct in COPD is, it has an atypical presentation because it might be just atypical chest pains, it might be some worsening dyspnea, and we can miss the diagnosis or delay the diagnosis. And as a result of which, the worldwide data, whichever country you take, these COPD patients, unfortunately, they are denied the aggressive interventional modalities like PAMI. And so also, somehow, for some reason or other, the standard secondary preventive measures which we use also are less used in patients of COPD. But if the patient has COPD, the mortality due to MI increases in COPD. Here, it is clearly seen, if these patients undergo PAMI, then naturally you can reduce some of the mortality. If they don't undergo PAMI, COPD patients have a worse mortality than those who are treated conservatively. Again, if patient has COPD and patient doesn't have COPD, then if the patient has COPD, naturally the CABG risk is high, and it is angioplasty which should be preferred over CABG because naturally the ventilator issues post CABG. The problem about secondary prevention in COPD. Now, common secondary prevention drugs which we use in COPD are ACE inhibitors, and we are worried whether cough can be more pronounced in COPD patients as such ACE inhibitors which can produce cough. Statins. Many of the COPD patients are cachexic, have pains, aches, and whether statins will worsen that. And beta blockers. Naturally, we are afraid whether it can increase bronchospasm in these patients. Now, it is clearly shown that use of ACE inhibitors is definitely beneficial in patients of COPD MI. And the incidence of cough is no higher than in general population. So every patient of COPD and MI should receive ACE inhibitor on discharge. Similarly, statins and COPD, all the trials, the meta-analysis show that the statin should be a part of our prescription regimen when this patient is discharged, like in any other patient. Beta blockers, the relatively controversial issues. But again here, the beta blockers have shown to be reduce the mortality in patients of acute myocardial infarction, especially the highly selective ones like bisoprolol. They are the ones should be preferred in COPD patients, and this has been shown in patients with COPD, in patients with asthma, in patients who have been on beta agonists. In all patient population, beta blockers should be given in patients of COPD when you are discharging him as a secondary preventive measure. And this is again a meta-analysis of beta blockers and COPD. Convincingly, beta blockers have shown to reduce mortality as a secondary preventive measure in patients with COPD. So, in summary, PCI, if indicated, should be performed in CAD with COPD. All secondary preventive strategies after MI hold true even in COPD patients. There is no increase in incidence of cough in ACE inhibitors. No increase in incidence of bronchospasm with highly selective beta blockers, and no increase in myalgia with statins. Thank you.
I think beautifully covered this area, and I agree that beta blockers, we tend to believe that beta blockers patient it's not an absolute contraindication, but when we start a beta blocker, we should take a considered opinion that we are starting a beta blocker in a patient who has COPD, and be alive to the possibility that you may need to decrease the dose or change the beta blocker, and we should be alive to that possibility. Other than that, I think the normal drugs which we hold to in other patients post-myocardial infarction should continue to be used in this group of patients, and angioplasty is a preferable modality of treatment, sure. I just want to make two comments here. One, that those of you who were there in PGI when I was there, I used to believe at that time, and I believe still, that if you want to be a good interventional cardiologist, you have to be a more or better than average diabetologist, a better than average neurologist, a better than average nephrologist, and a better than average hematologist. So that is what your suggestion would be. And today I learned that you need to be a better than average hepatologist also, probably. The second point I want to make is that in every particular field, there is a progress which is taking place. And we limit ourselves by going into a niche area and seeing that only in intervention cardiology or cardiology we are getting cutting edge technology and cutting edge medicine or devices. We should be alive to the reason that everywhere progress is taking place. So I, for one, take the earliest opportunity to attend a CME or interact with a non-cardiologist to know what progress is taking place in their particular specialty. When I was in PGI, I had cutting-edge projects with nephrologists on dialysis patient and coronary artery disease, and we did Holter, which is published in an international journal to show that VPCs and multiple problems arise in these patients. So I had a very active interaction with nephrologists. I had an attractive interaction with gastroenterologists to show heart failure changes in upper GI endoscopy. We had very interesting interaction with hepatologists and neurologists. With neurologists, we used to have a very close collaboration because of carotid artery disease interest. But the point I'm trying to make is that we should be knowing what extra is available in their particular specialty. And we should, diabetes is, unless you are a diabetologist, you can't be a cardiologist today. So not only you need to know your own specialty very well, you need to know more than an average specialist of other specialty if you're going to do justice to your patient. And moreover, these are comorbidities which are very common. Diabetes would be general population about 8 to 9%. In cardiology patient will be 13 to 14%, or maybe some of your OPD patient about 20% of patients. And we now know that in diabetes, not only we have drugs which are effective in diabetes are also useful in heart, we know there are drugs in diabetes which are more effective in heart failure patients than in diabetes themselves. So we need to know the pharmacology. We need to know the disease progress. So I think a very close collaboration with very specialties is required if you have to treat these elderly people with comorbidities, which would be common. And do not hesitate to seek their suggestion and interact with them. But do equip yourself also on progresses occurring in those particular specialties.
So basically, you have to be a very good physician.
Absolutely. I believe you should have at least 1 or 2, a minimum 1 year, but preferably 2 years of good internal medicine training before you actually become a cardiologist.
Yeah.
That is what I would suggest.
Yes, sir. I cannot agree more than that. What you said, absolutely true. I think way back 30 years back, Eugene Brunwald has called word cardiodiabetology. There is nothing like separate cardiology or diabetology. Eugene Brunwald himself said it has to be cardiodiabetology. They are just like the two sides of the same coin. Unless you are a good diabetologist, you can never be a good cardiologist. But if you are a good cardiologist, you have to have a knowledge of diabetes. But I must really congratulate Dr. Parale. Good cases, very stimulating cases you have shown, for which we didn't have any clear-cut idea. I think this intervention, what you showed today, has really improved our knowledge. Thank you so much. Congratulations.
Thank you. Thank you.
And Bali sir emphasized the fact that cardiologist is the king.
Dr. Bali sir is the king.
He's a monarch among so many of kings.
Maybe I would say I was very lucky because I did my MD from PGI. And I would say we had a very good internal medicine department. Balkrishna Sharma, PK Sharma was really very good. We had a good training in nephro, neuro, hematology, rheumatology. We were all rotated. So more than cardiology, I think our internal medicine department in those days was very, very strong. Those days the standard just come. We were all patient era people.
I could agree with Dr. Bhupen. I think I respect medicine department of PGI so much.
Yes.
That I would rank it one of the top departments of the world. I think much better than RNA. And I, for one, when I see a CV for somebody joining my institute, wherever I am working, the moment I see an MD medicine, I don't ask a second question. I take the person straight away. So therefore, it's a walking institute. You don't have to do anything. You just have to attend their radiology rounds from 12 to 1 on a Wednesday and see what is they are showing. You just walk through and you will learn gastroenterology. I learned my senior resident was Dr. Reddy, Dr. D.N. Reddy from Hyderabad. So the type of people you get and exposure you get in your 2 months of training in different specialties, whether it is nephrology or gastroenterology or cardiology or hepatology, is immense. So I would agree that although cardiologist is a monarch, but internal medicine is the queen of the board, queen of the chessboard. So if you are a good internal medicine person, rest everything becomes that much easier. So do spend your time to hone your skills on internal medicine always.
Before we end, I just want to
in the meantime, I think I'll request Smit to organize more such meetings for 2 reasons. At least our knowledge increases, we have a stimulating discussions, and we see our old colleagues. I'm seeing Dr. Bali after decades, Gurunath Parale maybe after 30 years I'm seeing him, 25 years, I don't know. So thank you so much, Smit. You have made us meet each other, though virtually, but let us have a meeting every 2 weeks or every 4 weeks or something, so that we all meet and discuss something new.
Sir, it's scheduled every alternate Saturday, sir. 8 p.m. every alternate Saturday. So this must be, I think, 5th or 6th meeting we are having. My personal request is that the next meeting I'm trying to make it the best I could. I'm trying to have the first 3-4 batches DMs to come, and it would be like there won't be any teaching, but it would be out of book teaching. What I wish to have on 15th August. So I request everyone that on that day, let's have a good presence. Basically, like in the start, I was saying that I wish to honor these fellows, and we go down starting from 1974 to Sourabh and then the next generation. So this in between every 2 or 3 months, we'll plan one such meeting where we'll take over 2 or 3 batches, depending upon the size we can accommodate. So 15th August, try to be there at 8 p.m. so that we can have. I have already approached 5 or 6 people, alumni hour. So that day at least we pay our respect to them. Dr. Parale, you had something.
Can you go back to my presentations?
Yeah.
Dr. Parale, one of these days, I'm going to see your other 130 slides.
I had already sent a request to him that the rest of
No,
the
better than slides. I just want to. That's what I want to concentrate on. This. I want you to see this. This is a book I have written.
Oh, great.
Acute coronary syndrome with comorbidities. I want your inputs about the different diseases which I have written there. I'd like to mail you all the copies. If you can give me your address, then I'd like to mail the copies, and I want your input and additions in my next edition.
Sir, the address I can give you because I have email as well as the addresses of everyone in a Excel sheet.
Okay.
So I'll send you on.
I'll courier the books.
Yes, sir.
To whoever is interested, and
I can ask the Mankind people also to contact you so that they can help you in this endeavor, sir.
Okay, sure.
That would be easier because putting labels and mailing would be a big task.
Okay, sure.
Can I give a suggestion?
Yes.
When you have the next edition of this book, I'm looking forward to reading this particular book. But listening to you today, I would like to say that when you are having a next edition of this book, do involve a hardcore interventionist to look at one aspect of the disease and your viewpoint on that. So we could have a more holistic approach to a patient of comorbidities.
Okay. Yeah, you will be the one who will be involved. If you
I do not know. I may be old and retired and tired by that time, but do get a hardcore interventionist to look at that.
Yeah, sure. Okay.
I think, sir, we can with this we can part for tonight, sir. It was a very learning experience for us. Very nice presentation, and we definitely hope this book as well as your presentation also, sir. Like Dr. Bali, I'm also interested in, I've sent you a WhatsApp request in between the lecture as soon as you said that I'll be stopping here. So thank you, sir. Thank you, Dr. Bali. Thank you, Ajit. Thank you, Dr. Desai and Sourabh.
Namaskar to all of you.
Thank you, sir, for your wonderful presentation, sir. Thank you so much.
Great.
Okay.
Thank you, everybody. Really enjoyed it.
Take care.